Welcome to PharmaDocs with your host, myself, Dr. Jay Resnick, and Dr. John Robertson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, good evening, John, or afternoon, depending on where you're, what time zone you're viewing us in. How's it going? I haven't seen you in a month.
Oh, no, Jay is going great. Just got off the pickleball court, got home, got cleaned up, and ready to do some PharmaDocs. How about yourself? Huh?
Well, I got my shoulder split off after 10 weeks last week, and so I can actually type now. And
Dr. Resnick is in the house
and feed myself.
Yes, he can now see patients, everybody. And look, Jay, I'm sure there are many of our colleagues out there that can have empathy for you because they've had that rotator cuff or labrum surgery as well too.
Yeah,
and,
it's not easy.
It's not easy, and we've got to have that to be able to do what we do every day. Huh?
Yeah. So my advice is don't go running in New Jersey at night after you've had dinner and a couple cocktails. It's a recipe for disaster, which I found out the hard way.
Oh, gosh. And, you know, disability insurance is not going to cover any of this.
I mean,
90 days, you'll be back.
I'm out for 8 weeks, so it's just under 90 days. And so all that money I've been paying to disability is going to stay with the insurance company. Oh. So, you know, it's a racket. That's why they build all those big buildings and control our lives.
Oh yeah. I even if it was over 90 days, I still don't even think they'd pay you. They'd come up with some reason to get out of it.
Oh yeah. You should see all the documentation they require that I actually couldn't work. And I didn't even fill it out because I knew I was going to be back at work before 90 days. So anyway.
It's a wonder why we even keep it, huh?
I mean, just for, I guess long term. I don't know.
But even long term, they probably fight you over it as well too.
Yeah. Well, I was bored to tears not going to work every day, but I went back today, actually last week and today to see consults, and I didn't really miss the place all that much. Having to deal with the cranky patients and the difficult patients and the staff issues.
Come on, we
and all
don't
that
have
stuff.
Cranky patients. Let's go, man. Everybody's so happy to come.
Yeah. So anyway, this is our PharmaDocs installment for August. Oops, wrong button. Wait a minute. What do I do here?
You just want the highlight on you, Jay.
There we go. That's the right one. Okay.
We're here on August 9th giving you the very best in pharmacology update that you deserve.
The rundown of most of the new drugs that were approved by the FDA in July, last month. We left a couple out, but we're going to cover.
We don't need to talk about a birth control pill, Jay. You know.
Well, yeah. I mean, you always have to worry. You know, you have patients that there could be some interaction. Same thing with how it's activated. If you give them antibiotics, it could inactivate the birth control pill for the cycle. But we got other things to talk about and our emergency of the month. So I guess let's get started here. We go to full screen. All right, here we are, August 9th. And of course, we want to start off by thanking our sponsors, who are iCore Connect with their product iCore RX. And they basically do electronic prescribing, and you can do it from your phone, you can do it from your laptop, you can do it from your desktop, you can do it from your iPad. It's nice to be able to do that way. We've got a similar system at my office, and it's so nice, when I get a call from a patient that needs a refill or has an issue, that I can just do it on my phone and not have to wait on hold for 20 minutes for the pharmacist to come on. So That's definitely technology has taken us a long way.
And the thing about that too, Jay, is like, how many times have you had your staff call the pharmacy, get the voicemail, they leave a voicemail, then the patient goes to the pharmacy, and then the pharmacist has a way out by saying, we never got the voicemail.
Yeah. And now you can say, you got the order. I have a verification right here at exactly 4:02 in the afternoon, you received it.
Absolutely.
So, yeah. So if you're not e-prescribing, I'm sure, I think we all have to now. But if you're not, definitely a good way to go. And it's a good way to track all your patients' medications as well as see what other things they're on. And then Balance Pharma. And they are going to rock the world of local anesthesia.
Oh, absolutely.
By making a little tweak to a normal dental carpule to buffer the anesthetic and make it less painful. Because that's the thing the patients hate is the burn. The pinch isn't so bad as the burn from the local, and it also kicks in a little quicker. So you can read about them, get some more information at balancepharma.com.
I cannot wait for that to come out, Jay.
Wait a minute, what happened to the other ones? That's strange. We had a couple more. Huh. What happened to them? All right, well, we'll just have to mention them by name, and that's Vesper Institute, which is where we teach an IV sedation course. They've got all kinds of courses for dentists, vesperinstitute.com. And then Fortune Law Group, that's in business to not necessarily protect you from malpractice
suits, your assets,
but protect your assets and protect your practice and your
protect your license.
Yeah. And they're at... their website is
fortunelawfirm.com.
I think it's Fortune
Law
Google Fortune Law Firm, it'll
Jay,
come up.
They're so good at what they do. If you have an event in your office, and you will, it's going to happen sooner or later. There's a lot of dentists saying, "Hey, I will never have a medical emergency." You're going to have one. Okay. All right. And I like to call them MENOs, MENO, medical emergency with negative outcome. When that happens to you, many people are told to call their malpractice carrier, but if you're tied in with the Fortune Law Firm, they want you to call them first.
Yeah.
They're about trying to save your license. Ask yourself right now, what would you do without your license? How would you make a living?
Yeah.
Fortune Law Firm wants you to keep your license.
Yeah. Uber's looking for drivers all the time, but who wants to go through all the school we go through to do that?
Oh, all right.
All right. So let's move on to our drugs of the month.
We got a new format, Jay. How do you like that?
Huh? I like it. Yeah, it looks good. So the first drug is Kisunla, which is donanemab AZBT, which would, with that suffix, you would think that it was a biosimilar, but it's not. It's actually a new drug.
Yes.
And so this was approved on July 2nd, and it's an injection for treating Alzheimer's disease. And so this was basically approval was based on a number of studies which show that it's safe and actually effective. And that's been one of the issues with some of the Alzheimer drugs that have come out in the last year or two, is that, they're safe and they do what they're supposed to do, but they don't necessarily change outcome at all. And this actually has been shown to improve outcome. And so what they did is look at two groups of patients, ones that are patients that were not very advanced in their disease, so early Alzheimer's disease, as opposed to, middle to late. And they judged that by the number of amyloid plaques and assay of tau protein, which is part of the amyloid pathology, and to stratify the groups. And what they found was that it significantly slowed the clinical decline in both groups, but got the best benefit from the least advanced. So if you can, their physicians or neurologists can diagnose Alzheimer's early, this drug seems to really alter the course. It doesn't stop it, but it really slows it down And let's see what they say, 39% lower risk of progressing to the next clinical stage. And
the key is the reduction of the amyloid plaques.
Yeah.
All right, because the more they accumulate, the greater the significance or severity of that person's Alzheimer's, Jay. I mean, man, this is, since we've been doing PharmaDocs, we've seen multiple drugs starting last year, not to treat the symptoms, but to actually treat Alzheimer's.
Right.
And this is only going to get better because the amyloid is the issue. It's in that area of the brain called the substantia nigra. And that's where the amyloid plaques build up. And this is where we get Alzheimer's. And so if we can reduce this, and like you just said, it's got a reduction of the amyloid plaques on an average by 61% at 6 months. All right?
Pretty significant.
Of course, and it keeps growing as the study goes longer.
Yeah.
And
so there are a bunch of slides missing. That is bizarre. Slides in there basically showing what's happening in Alzheimer's and the amyloid plaques forming, and as it affects more and more amyloid plaques, it goes along with progression of the disease. So it's a brain disorder that slowly destroys memory and thinking skills, and it's very common among older adults. And the etiology is not fully understood, but in addition to the amyloid plaques, one of the thoughts is that it could be due to degeneration of acetylcholine producing neurons in the brain. And so this drug, Zunveil, works. It's also a drug for Alzheimer's, but rather than stopping the progression of amyloid plaques by being an acetylcholinesterase inhibitor, it increases the amount of acetylcholine that's available in the neuromuscular or neurogenic junctions in the synapses. And it's a prodrug of galantamine, which is a drug that's been well established under the name of Remenil, which is also acetylcholine esterase inhibitor to slow the progression of the disease and basically improve some of the symptoms.
So see, this doesn't treat the plaques.
Right.
This just helps to treat the symptoms.
Yeah, increases.
And like you said, this is a prodrug.
Like
so
Aricept, very similar to that.
So it's a congener of galantamine. And so they've taken that drug and added another molecule there to make it a better drug as well. Right. So benzgalantamine is the prodrug.
Yep. It's a delayed release oral tablet, enteric coating, twice a day. And of course, what drugs don't have the side effects of skin reactions, cardiac, gastrointestinal, bladder, respiratory. It's so funny when I'm on the treadmill at the gym, they have a bunch of TVs, and it's like every single ad. I mean, you can't help looking at them, even though I usually watch Netflix, some of the comedy stuff while I'm on the treadmill. But every single ad is either a prescription drug or an injury lawyer. And when they rattle through all the side effects and possible, warnings with these drugs, it's amazing that, that anybody wants to take them. I mean, sometimes the side effects are worse than the actual disease. So anyway, so common reactions: diarrhea, nausea, vomiting, decreased appetite. Those are all kind of you see that with just about every drug. So nothing special there. All right. So the next one is epsequili, which actually, let me go back for 1 second. We didn't cover. Kisunla notice it's an EMAB. So this is a monoclonal antibody drug, which means it's going to affect immune function. So you want to make sure, your patients have a higher risk of infections. or more severe infections. So you want to make sure they're adequately covered with antibiotics. So same thing here. This is a human monoclonal antibody that was approved in July 19th last year. And this drug is used for treating something called paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome. And so this is this one is a biosimilar to Soliris, but does not have an interchangeability designation, which means when the physician prescribed one or the other, that's the one they have to get. And this is given by intravenous infusion over 35 minutes in adults and a little slower in kids. And it was based again on some studies that showed there was a significant improvement and slowing of progression of the disease with this drug.
And you notice that we talked about a drug back in May as well, Bikimva.
Yeah.
Which is also approved as well too.
Yep. I don't know where all the other slides went.
Wow.
That kind of describe all the different things we're talking about.
Yeah.
So we'll just have to improvise here. Then the next one is Lexelvi with duroxolitinib, and based on the suffix of the name INIB, you know that this is an immune modulator, an inhibitor of immune function.
Yes.
And so this is used for treatment of alopecia areata, which, actually showed up there.
There we go.
So this is what it looks like.
Correct.
It's basically a patchy loss of hair that can be, small patches all the way to something like this, or even cause total baldness. And it's thought to be an autoimmune disorder that causes this. And so this drug, Lexelvi, is a Janus kinase inhibitor. We've talked about those before.
Yep.
And so it helps modulate the autoimmune effect, the immune system attacking the hair follicles, resulting in the hair loss. And it's a JAK1, JAK2 inhibitor that targets the gamma C cytokine and the interferon gamma IFN gamma, signaling the pathway to reverses hair loss. And so these are kind of some of the things that will contribute to it, in addition to autoimmune, local skin disorders, nutritional deficiencies, after acute illnesses, stress, hormones, drugs. These can all either lead to the autoimmune disorder or certainly make the symptoms worse. Wow, what's happening to these slides? Again, based on a number of clinical trials which showed that it improved, actually caused hair to regrow. On the baseline study baseline, patients had only 13% of their scalp hair, and was met with more than 30% of patients taking it experiencing 80% or more scalp hair cover, and 25% had greater than 90% scalp hair return coverage at 24 weeks. So
there's going to be off-label use of this drug for other things, for people just with balding.
Yeah.
Mark my words.
Yeah. Oh, I'm sure it will be.
I mean, look at those stats. And 90% had, look at that.
Or 25%, greater than 90% approval.
90% of scalp
improvement,
hair coverage. Yeah.
Yeah. I mean, that's amazing.
That is.
It's an oral tablet twice a day. Again, since it's an inhibitor of the immune system, of course, it has a higher risk of serious infections and all-cause mortality, increased risk of malignancies, especially lymphomas and lung cancers, cardiomyopathy, cardiovascular events, and thrombosis. So they need to be careful. Patients who are smokers, for example, or any anyone who's on a drug that can increase coagulability is a big precaution. And of course, this, again, the common side effects are headaches, pharyngitis, fatigue, increased weight, lymphopenia, thrombocytosis, very common side effects. But the serious ones those are the ones we have to look out for. The next drug is
it Urzofri?
I think Urzofri, yeah.
Urzofri, yes. And paliperidone. And this drug, Jay, is for schizophrenia or schizoaffective disorder.
Exactly.
And it is an extended release injectable suspension.
Mm-hmm. Yeah. And these are changing the game when it comes to treating schizophrenia and schizoaffective disorder.
Yeah.
It's used an atypical antipsychotic used for the treatment, and they're both characterized by hallucinations, delusions, disorganized thinking, and what happened to my slides with all they? Oh, here we go. It's at the end. So basically, it's a drug that is paliperidone palmitate, and it's hydrolyzed to paliperidone, which is similar to risperidone, which has been around for a long time. But again, this is a long-acting time release, and it's the same drug that was approved in 2006 under the brand name Invega, but this is a once-a-month injection. And so that is a significant improvement, because with schizophrenics, of course, compliance with medication is a real problem and leads to continuation of symptoms. So let's just kind of go here.
Yeah,
some of the
this is a great slide right here to help people really understand what is schizophrenia.
Yeah. A lot of things occurring, social isolation, compulsive behavior, self-harm, amnesia, hallucinations, rapid speaking, fatigue. But early signs are like a withdrawal from family and friends. They don't really know what causes this, but there is they think there's some familial factors involved. And treatment really involves drugs. This is not something that can be treated by psychotherapy. These patients really need a combination of antipsychotics. And, as I mentioned, the medications all cause some fatigue in these patients. And so patients don't like the way that they feel when they take these medications. So they may take them for 1 or 2 days and not take them anymore. And then all their symptoms come back, the hallucinations, the delusions, disorganized thought, speech, anhedonia, which is basically avoiding anything that really causes or creates pleasure for you.
Yep.
Avolition, which means you basically don't want to do anything. Blunted affect, which is where, they're
would that describe you going back to work today? Abolition?
Yeah, kind of. And blunted affect too. Okay, I'm back. What am I going to do? Those memory issues, inability to process social cues, and impaired sensory perception. And so again, it has probably some genetic components, brain chemistry, environmental, triggers, and that leads to all this. And it's a lifelong diagnosis. It's not something that gets better. It's usually diagnosed in the early 20s, late teens, early 20s in patients. I have had a classmate from high school who's a brilliant guy, got into Harvard, and in his first year, he started not going to class and not passing exams, and he was diagnosed with schizophrenia. And he basically, this is a while ago, was not compliant with the medications, and he just went downhill and ended up like passing away at the age of like 32 or something like that. And I only know that because his parents actually ended up being patients of mine. So it's, this these long-acting monthly injections are something that really will improves compliance and improves symptoms and can get patients back on the right track.
Do you feel like people with schizophrenia, Jay, like the stigma they have, they're going to be just this aggressive a person that can attack you at any time?
That is one. Yeah, because there's of the hallucinations. They think someone's talking to them to tell them to do something. They have visual hallucinations. They may think, you're holding a knife or a gun against them, or they're in danger. So yeah, it does. I mean, especially, I don't know how the homeless problem is in Hattiesburg, but in Southern California, especially LA, it's really bad. And you hear about attacks almost daily in the news from patients who are schizophrenics not taking their medications, who have some type of hallucination or delusion and end up harming somebody. And sometimes it's, fatality. So it's a serious issue that needs to be treated. And we can go on about this forever. As far as how it relates to the homeless population, but let's move on to our.
Let's look at the medical emergency
of the month.
The month.
Yeah. So it can happen anytime at any time of the day in your office or anywhere and that's sudden headache, dizziness, and sudden confusion. Actually sounds like me today. But in addition, numbness of the face and facial droop.
And you don't have the last two.
Yeah, what happened to them?
No, you don't have you don't have.
Oh, I don't have the last two. I don't have the last two. Yeah, yeah, just the first three. And that course
would be a
are signs of a stroke, cerebrovascular accident, which sometimes is called a brain attack. It's analogous to a heart attack, and there are two main types: a hemorrhagic stroke, which is about 20% of them, and an ischemic stroke, which is about 80% of them. The hemorrhagic stroke is caused by basically a rupture of a cerebral blood vessel, which causes blood to leak into the brain. And an ischemic stroke is caused by a blockage of one of the cerebral blood vessels.
So that's why we don't give aspirin when somebody's having a stroke, because you don't know what type of stroke they're having.
It is. And that's really important when we talk about what you do.
And the other thing too, if you go back to the algorithm, the position.
We'll get to it in a minute.
All right.
But one of the mnemonics is used for diagnosing someone having a stroke, and also TIAs, which is like a mini stroke, are the mnemonic is be fast. And that really kind of describes how you have to manage this. But patients will have balance issues. They'll be uncoordinated. They may have double vision, blurry vision. So that's the E. Facial drooping, of course, which is going to be on the side of the stroke that they're having. And then systemically, their arms and legs they'll have weakness on the opposite side. So arm weakness and difficulty with speech. And they can't, not only not speak well, but they can't repeat very common phrases that you may ask them to repeat, like the quick brown fox jumps over the lazy dog. That was one we learned in neurology in med school to use. And the T in the Be Fast is call 911 immediately. Even if you think it could be a TIA, the patient's had TIAs before, you don't know if this is going to be a full-on stroke or not. So you've got to call 911 as soon as you recognize these symptoms. So here's our algorithm again.
Yeah.
So sudden headache, as we talked about, sudden weakness, trouble speaking, facial drooping, confusion, dizziness, loss of balance, etc. Number one, call 911 before you do anything else. Correct. Stop treating the patient, put them in a comfortable position, and then go through your emergency plan in the office.
And note, Jay, sitting upright.
Yeah.
Not supine, not legs elevated above heart.
Yeah.
Okay.
Yeah.
Sitting upright. If you suspect a stroke, get the patient sitting upright.
Yeah.
If it's a single,
or at least up at least 45 degrees.
Yes, if it's a syncopal episode, then you get them supine, legs elevated above heart. You are responsible for the position of this patient, determines their outcome.
Yeah, and of course, you want to make sure that they are breathing at a normal rate. Their O2 saturation is where it should be, above 95%. That their heart rate is not over 100 or less than 60. And of course, they have a pulse and they can respond to you. Yeah. So the most important time is to record their vital signs, but record the exact time that the symptom onset began. So this is really important when EMS gets there to let them know, because time is of the essence.
Time loss is brain lost.
Yeah. So basically the timeline is that you call right away so that the EMS is there like within 10 minutes of your call. They get the patient, they get the patient to the ER within 10 minutes of leaving your office. And
stroke team is activated.
Stroke team is activated. Sometimes, not every hospital has a stroke team. They may have to be diverted to a hospital that has a stroke team. But once they hit the doors of the ER, they know that this is a stroke patient coming in. They start the stroke protocol. Time has been ticking. They get them right away to take them directly to CT or MRI to see, is this an ischemic or hemorrhagic stroke? If it's a hemorrhagic stroke, they need to go to the operating room to stop the bleeding. If it's an ischemic stroke, they need to be on some clot busters, the TPA, tissue plasminogen activator. Yep. And you can see here on the timeline that should be given within 60 minutes of arrival to the ER or ED, emergency department. And so time is critical to minimize sequelae of the stroke. And some of the long-term sequelae are things like, if it affects the right hemisphere, patient's attention span, whereas left hemisphere is more speech, expressive speech, understanding math. Right side is going to be more, drawing skills, recognizing faces, emotional stability, being able to estimate distances, how far they are away from objects. So that's the right hemisphere, which affects those kind of cognitive functions, and left hemisphere is more the kind of the logical side. And so this is just another image showing the same thing. Essentially, the left hemisphere is speech and communications, short-term memory loss, visual issues, paralysis. Right side is more the kind of artistic and more kind of behavior and that type of long-term side effect. So again, the moral, or not the moral of the story, is the lesson is, with a stroke, recognize it quickly, be fast, call 911 immediately, get the patient positioned, make sure you monitor their vital signs, that they're breathing, their airway isn't obstructing, because they could be, lose consciousness completely. So you got to make sure that they've got an open airway, they're ventilating, they're oxygenated, and keep the patient in as good a condition as you can until EMS gets there. All right, so now we're on our shameless plugs for some of the things that we do on dentallearning.net. Is our PharmaDent.
Shameless plugs.
I mean, what else can you call it, right? And as we talked about,
productive distance learning. That's what it is.
Okay. And PharmaDent, John, that's kind of your baby. So will you kind of describe it in a little detail?
I mean, it's a pharmacology update, Jay, that just covers 15 different medication categories. We got to know all about these drugs, whether it be hypertension, congestive heart failure, arrhythmia drugs, diabetic drugs, respiratory drugs. I mean, the list goes on and on and on. We've talked about this for years.
Yeah.
If 100 new drugs come out every year and you've been out 20 years, that's 2,000 new drugs. Yeah. And,
and that's what we talk about on PharmaDocs. PharmaDent are the drugs that have been around for a while that you really need to know what they are, how they work, how they interact with your dental treatment.
Right. And then we talk about immunosuppressants and all that because we talk about UMAB, EMABs, INIBs. Yeah. I mean, these are all, whether they're immunosuppressants or immunomodulators, these are going to affect the immune system.
Yeah. So and when these patients walk into your office, ding, 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 you know what this drug is. Yeah. Even if you don't know the specific drug, you know what category it's in.
Yes.
And
it's antibiotic time.
Deal appropriately with this patient. No, is this a drug that's going to inhibit, let's say, cytochrome P450 system, which metabolizes a lot of drugs like benzodiazepines that you may be giving the patient if you're doing oral, PO or IV sedation. And the next one is our DOMS Dental Office Emergency Simulations. We've got 24 medical emergencies and broken up into modules of 6. Oh, yeah. Again, $99 for 4 hours of, or 2.5 hours rather, of self-study CE. And then our IV sedation course.
Love this.
Vesper Institute.
Yes.
VesperInstitute.com. Probably one of the most comprehensive IV sedation courses that you'll ever take. We have people that come to our course that have taken other courses before and even gotten their IV sedation certificates, their permits, and just can't remember what they learned. There was no follow-up. They didn't know what equipment to buy. They were just kind of left hanging after spending $25,000.
Yeah.
And so we have just a really winner course, and we'd love to see you there if you're interested at all in bringing IV sedation into your practice, which really changes the game. Think of all those patients out there who are too anxious to see you, that need restorations, that need root canals, that need extractions, that need all kind, restore.
Jay, like we talked about, why would you want to do a root canal for 2 hours and the patient's under local and they might just be real apprehensive about it? Look, the same 2 hours could be done with IV sedation. Yeah. Now everybody's happy. A patient's going out singing your praise. Like, hey, I went to Dr. Resnick's office. He put me to sleep or got me, consciously sedated and did the root canal. It was a beautiful experience.
Yeah.
All right. It's just
which Dr. Resnick, because this one doesn't do root canals.
Yeah. Well,
I haven't done one since I graduated dental school.
Your revenue cycle management will be on the increase size here.
Yeah.
Okay.
I mean, John and I, we use IV sedation, deep sedation, general anesthesia on probably 70 to 80% of our patients, and we couldn't do the things that we do.
99.9% of my patients. All right. You're going to sleep.
Yeah.
And
it just makes a better
makes
experience
dentistry
for
fun.
Everybody. Yeah.
Makes dentistry fun.
Yeah, exactly. And then John's got his pediatric medical sedation emergency airway course.
Jay,
again, on dental learning.
Yeah, there's no course out there. I mean, people ask me all the time, where can I get a course on pediatric, medical sedation, airway emergency? I said, on dental learning. Done.
Yep. And, 3 credits for $30, $10 a credit. I mean, a bargain.
Yeah. Okay.
So we will be back again on September 13th.
See y'all
talking
then.
About the drugs that were approved by the FDA this month, August, as well as our medical emergency of the week that I know you all look forward to. And so we want to thank you for being here with us. and we will see you next month.